Hi guys, welcome back to the channel. Today we are discussing the CRASH 2 trial, effect of tranexamic acid on death, vascular occlusive events and blood transfusion in trauma patient with a significant hemorrhage.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in the network for advanced understanding of educational content.
Clinical question: in trauma patient with a or at a risk of significant hemorrhage, does early administration of short course of tranexamic acid affect the mortality, incidence of occlusive events and amount of blood transfusion? Designed for this study, randomized using the 24-hour free call service balanced by the center with the allocation sequence based on the block size of 8. If no telephone is available, taking the next consecutive randomization packed, multi-center, double-blinded, placebo-controlled with identical treatment packs with a 20,000 patients with a study power of 2 to detect the 2% survival advantage from the baseline of 20% at either 85 power with alpha error and 95 power with alpha error. Setting for this study: 274 hospitals in 40 countries. Enrollment began with May 2005. Population for this study included adult age of more than 18 years with a trauma present within 8 hours of incident, either significant hemorrhage or who considered to be the risk of significant hemorrhage. Systolic blood pressure is less than 90 or heart rate more than 110 beats per minute. Responsible doctor was substantially uncertain about the whether or not to treat with tranexamic acid. Exclusion criteria: clear contraindication to tranexamic acid. 20,207 patient trauma patient randomized and 20,127 analyzed under the intention to treat basis. Evenly matched groups within 39 protocol violation in each group. Intervention: loading dose of 1 gram tranexamic acid infused over the 10 minutes, followed by intravenous infusion over gram 8 hour. Control: placebo 0.9 only saline. Outcome: primary outcome death in hospital within 4 weeks of injury, significant reduction in intervention group. Secondary outcome: no significant difference in intervention in control group. Recipient of blood product transfusion, surgical intervention, occurrence of vascular occlusive episode, stroke, myocardial infarction, pulmonary embolism, clinical evidence of death and thrombosis, unit of blood product transfused, dependency on at hospital discharge or with 28 days age staying in hospital. This is the primary outcome: death in all cause, tranexamic acid 14.4, control 16, bleeding 4.9, control 5.7, vascular occlusion 0.3, control 0.5, multi-organ failure 2.1, control 2.3, head injury 6, control 6.2, other causes 1.3, 1.4. Secondary outcome: you can read this, you can screenshot this tabular form. Strength for this study: the randomized, blinded, placebo-controlled, pragmatic study. Large number of patients included. Randomization on based on subjective opinion of a treating physician. Not standardized criteria for the treatment use of tranexamic acid. Selection bias: no stratification of injury severity. Follow-up period of only 28 days was incomplete. Non-standardization on the use of fluid blood products in group. Trenexa did not reduce the transfusion rate. Only 5% of patients in both groups actually died in hemorrhage. Author conclusion: Trenexa safety reduced the risk of death by using trauma patient in this study. On the basis of this result, Trenexa should be considered for using bleeding trauma patients. The study suggests that the occlusive reduction in mortality with the use of Trenexa in a trauma patient is very small. Neither did it reduce the amount of blood product administered. However, Trenexa is unlikely to cause harm. Hence, it will continue to part of practice in management of the bleeding trauma patient.